Welcome, our dear colleagues. We are today, we're going to start in the clinical nutrition in chronic kidney disease. This is one of our sessions in the program of CME of Oman Society of Nephrology of Transplantation. Today, we will have Mr. Shabib Al Kalbani, Head of Hospital Dietetic and Catering, Directorate General of Specialized Medical Care. He finished his academic qualification with master's degree in clinical nutrition from Rompton University in London, UK, to 2013. Also, PSc Human Nutrition and Dietetic, Sultan Qaboos University, 2006. He also took 2 courses, Nutrition and Diabetes, Gosling Diabetes Center in Harvard University Medical School, 2014. Also, an Advanced Patient Prescription Nutrition, Harvard School of Public Health, 2023. Welcome, Mr. Shabib Al Kalbani. You can start now.
Thank you very much, Dr. Tariq, and welcome everybody to my presentation on updates in medical nutrition therapy in chronic kidney disease. Allow me to just brief introduction of who I am. I started my journey in the Ministry of Health in 2007, and I worked with hemodialysis patients mainly as part of my job as a dietitian or clinical nutritionist. Okay, so from 2007 to 2015. And from 2015, I went to the Central Ministry of Health at the headquarters. And at the moment, my main duties include supervising the hospital dietetics and catering sections in these hospitals. So we're seeing patients inside hospitals. We're seeing mostly clinical cases of ICU. We see surgery. We also see complex burn, immunocompromised patients, and we deal with the nutrition support, whether it's oral, enteral, and parenteral. Since this webinar is, as I understand that the audience here is not just dietitians, it's also physicians, nurses, other allied healthcare professionals. I would like to show you from this presentation what our scope of practice includes in dealing with the patients with chronic kidney disease. Okay, is everybody able to hear me? Just wanted to confirm.
Yes, go on.
Okay, great. Okay, so this is the first slide. Okay, so what I will be including in this webinar is some information on the functions of the kidney, because I wanted to show the audience how it's related to the patient's nutritional status. I'm going to also give some briefing on nutrition assessment, but mainly what's going to happen here is I'm going to be reading from one of the latest guidelines in nutrition management of renal diseases. And these are a combination of KDOQI guidelines and the Academy of Nutrition and Dietetics Renal Group guidelines. So they've merged together. When I first started in the Ministry of Health in 2007, I used KDOQI guidelines, which were separate. And now they've sort of combined. And in this presentation, I'm going to be reading some of the clauses in this guideline, not all of it. Okay, and hopefully I'll be able to share this guideline with you sometime after this lecture if I receive all your emails. So let's begin. I first like to begin talking about the functions of the kidney as they're related to nutrition. And I think this is quite self-explanatory here. The regulation of bone mineral metabolism, the acid-base regulation, okay, and the salt and fluid regulation. Consider if the patient does not have any of these functions, how his health will deteriorate. And also the main function, of course, is filtration. There's also the regulation of red blood cell production. And this is how the patient's iron and hemoglobin levels are stabilized. And as I said, regulation of bone mineral metabolism. And that way his calcium status is regulated, and his bones are quite strong. Okay, and also the activation of vitamin D. Next slide, please. And I think I don't need to explain to you that this is the functional unit of the kidney, which is the nephron. Okay, and what happens to the nephron goes through 4 stages. Filtration, which is plasma is filtered from the blood. Reabsorption, useful materials like solutes and water are reabsorbed. Secretion, metabolic waste products like potassium and phosphorus and medication waste may be secreted too. Excretion, remainder is excreted as urine. Next slide. Okay, so this is sort of like a flow chart of the scope of practice of dietitians in a clinical setting such as the renal clinic or hemodialysis clinic. Okay, the first thing that happens is what's called a nutrition screening. Nutrition screening is something that mainly nurses do, and correct me if I'm wrong. Okay, there are various nutrition screening tools. It's sort of like a 5-minute questionnaire that addresses the patient's nutritional status in a very quick manner, and identifies the patient, whether the patient is malnourished or the patient just needs to be monitored again through a score. Okay, based on that score, a patient is referred to a dietitian or a clinical nutritionist, a certified one, a qualified one by his government, okay, to carry out what's called a nutrition assessment. Nutrition assessment is something that is much more detailed and much more depth. They follow the a DIME method, okay? So the dietitian uses the patient's anthropometric measures, the weight, the height, circumference, and also we've got new tools coming up like the calf circumference and using the waist and hip ratio. Okay, also interpreting serum investigations, and especially since we're talking here about renal patients, we're looking at the patient's serum potassium, phosphorus, trace elements, albumin. Then and also for clinical signs and symptoms and what's called the nutrition-focused physical examination. Okay, and we're not forgetting here the diet history. Various diet history methods are used, and ideally, what I used in my setting is a 24-hour recall in combination with a food frequency questionnaire. So what you want to do here is to understand that patient's dietary habits. You need to understand what a typical day looks like, and combine that with the food frequency questionnaire, where you can ask the patient how often he's taking from this food or from that food and what portion sizes. Then we have what's called the nutrition diagnosis. And a nutrition diagnosis is a statement that you end up with after carrying out the entire nutrition assessment, after you looked at all the aspects of that patient's dietary habits, the financial status, the economic status, and come up with one sentence that summarizes what exactly is wrong with this patient, and that creates a platform to analyze or to come up with a nutrition intervention for that patient. And that nutrition intervention is a medical nutrition therapy plan, and it can also include a meal plan, a typical meal plan, calculated in terms of calories, protein, trace minerals, and fluid. And then that is followed by a nutrition monitoring and evaluation, which should take place on a regular basis. Okay, and it's going to depend from one patient to another. If that patient needs further assessment or evaluation, the patient will be seen after a month. If not, then maybe after 6 months. Okay, it's going to depend. Next slide, please. Okay, so now I'm going to read directly from the guideline itself. And as we go along, I would like you to think about how these can be implemented. Okay, and as I said before, I didn't put all the clauses within that guideline. It's actually quite long, and I thought that maybe I'd focus on the most important ones. Okay, how are we doing for time, by the way, Dr. Tariq? When the time comes to an end, please let me know. Okay,
45 minutes your time, no problem.
Inshallah. Okay. All right, so let's start with nutrition screening. And what we say about nutrition screening, that it's a tool that ideally should be done by a nurse, okay, which is a 5-minute tool, and that identifies whether a patient is malnourished or his nutrition status is normal and just needs to be rescreened at another time, okay? So in adults with CKD, chronic kidney disease, stage 3 to 5, or post-transplantation, it is reasonable to consider routine nutrition screening, at least biannually, with the intent of identifying those at risk of protein energy wasting. So as you can see, once every 6 months, and of course, if that patient's nutritional status is compromised, you'll need to see him more often, maybe at least once a month, okay? In adults with CKD 3 to 5 or post-transplantation, there is limited evidence to suggest the use of one tool over others for identifying those at risk of protein energy wasting. Now, there are various tools. There's what's called the malnutrition versus screening tool, or we prefer to say MUST tool, that we are using here in our Ministry of Health. We've already integrated that into our hospital settings, and we're working on adding much more nutrition screening tools, okay, those that address children, those that address specific diseases. And there is also one tool called the iNut screening tool, okay, which we're actually working on it. We're putting a pilot study on it at the moment, and hopefully we'll be using it in the near future. Okay, there are also many screening tools which I did not mention here, but then the message that I'm trying to send to all of us here is to find a tool that is easy to use and something that can be accessible and doable. Okay, it does not take up much of a nurse's time, but also identifies important information. Next slide, please. Okay, so after nutrition screening, based on the screening score, a patient is referred to a dietitian. In adults with CKD 3 to 5 or post-transplantation, it is reasonable that a registered dietitian nutritionist, or in our case here, a nutritionist that is working under the Ministry of Health, or someone who has the title under the Ministry of Health, or an international equivalent, conduct a comprehensive nutrition assessment. Okay, so that includes, but not limited to, appetite history of diet intake, appetite, history of diet intake, body weight and body mass index, biochemical data, anthropometric measurements, and nutrition-focused physical finding, at least within the first 90 days of starting dialysis, or annually, or when indicated by nutrition screening or provider referral. Next slide. Okay. Now, when it comes to body mass index, okay, I'm sure that all of you have heard of body mass index. 30 and above is obese, 25 and above is overweight, okay? And probably in Asian countries, the criteria is slightly less than that. So in adults with CKD, stage 1 to stage 5D, D stands for dialysis, by the way, or post-transplantation, who are clinically stable, it is reasonable to measure body weight and BMI and to monitor for changes in body weight, BMI, and body composition as needed, okay? At least monthly in maintenance hemodialysis patients and in peritoneal dialysis patients. At least every 3 months in patients with CKD 4 to 5 or post-transplantation. At least every 6 months in patients with CKD 1 to 3. Next slide. In adults with CKD 1 to 5 or post-transplantation, it is reasonable to register a dietitian nutritionist or an international equivalent or physicians to use clinical judgment to determine the method for measuring body weight. For example, actual measured weight, history of weight changes, serial weight measurements, adjustments for suspected impact of edema, ascites and polycystic organs due to absence of standard reference norms. So this is a message to the physician and the dietitians to exercise clinical judgment in finding out what is the right weight. Next slide. Resting energy expenditure. So resting energy expenditure is part of the total energy expenditure which the patient, which we use okay, eventually, when providing a medical nutrition therapy and a calorie-controlled nutrition plan. So in adults with CKD5 or hemodialysis who are metabolically stable, we suggest that in the absence of indirect calorimetry, which I'm not sure if the indirect calorimetry is mainly used for research purposes, and it's not always available. Disease-specific predictive energy equations may be used, and one of them is this one: total energy expenditure, resting energy expenditure plus activity-related expenditure. May be used to estimate resting energy expenditure, as they include factors that may influence the metabolic rate in this population. I'd like to mention here is that so when we don't want to use the total energy expenditure, we use on average 35 kilocalories per kilogram per day, and that's for a normal BMI. If the patient is underweight or overweight, we modify the calories accordingly. Depends on what goals we're trying to reach. Okay, and this is mainly the dietitian's job to do. Next slide. So, considerations when assessing dietary intake. In adults with CKD 3 to 5 or post-transplantation, it is reasonable to assess factors beyond dietary intake. Okay, so for example, medications use. Is he taking glucophage? Is he taking Coumadin? Okay, is he taking other medications that may interfere with the patient's nutrient absorption or nutrient digestion? The patient's knowledge, the patient's beliefs, the attitudes, behavior, access to food. Is the patient able to cook for himself, or is there someone else who cooks for him? Is it a patient who's educated? Is it a caregiver who is educated or not? Is the patient suffering from depression or any cognitive function? Okay, and all of these are needed to effectively plan nutrition interventions and aid prognosis. Next slide. Alternative methods of assessing dietary intake. So in adults with CKD 3 to 5 or CKD 5 maintenance dialysis, 24-hour food recall, food frequency questionnaire, and NPCR may be considered as alternative methods of assessing dietary intake and protein intake. And this is what we as dietitians mainly use. There are other dietary intake methods that can be used. Okay, it depends on how educated the patient is. You might, for example, ask the patient to write in a diary over the next 3 days what he or she has eaten. But then, of course, that comes with limitations. It's not always a positive thing. The patient might be educated and may write exactly what he or she is eating. But then, on the other hand, it's very difficult to say whether the patient has changed his eating habits just to please the dietitian, or the patient may not be reporting everything that he or she is consuming. So that might be a limitation too. Again, the message here is that there are multiple dietary methods and each one has its own advantages and disadvantages. Next slide, please. Medical nutrition therapy. So, assuming that the patient's nutrition diagnosis is stated, MNT provision by qualified dietitian or clinical nutritionist. Okay, and again, I want to mention that it's a dietitian or the clinical nutritionist that provides the medical nutrition therapy. Okay, regardless of which clinical setting you're in. Goals are to optimize nutritional status. Okay, so the patient who has kidney failure or renal insufficiency, I'd like to optimize his or her nutritional status given the complications that he's going through, and to minimize risks imposed by comorbid conditions. So, for example, if the patient has diabetes or hypertension or dyslipidemia, or is allergic, or has gluten sensitivity, then I have to work based on that. And alterations in metabolism on the progression of kidney disease and on adverse clinical outcomes. Okay. The MNT, the medical nutrition therapy, should be tailored to the individual's needs, nutritional status, and comorbid conditions. To monitor and evaluate appetite, dietary intake, body weight changes, biochemical data, anthropometric measurements, and nutrition-focused physical findings to assess the effectiveness of MNT. Of course, that comes after the follow-up. I'd like to also mention one more thing here with the medical nutrition therapy. If that patient is a child or an adolescent, which I'm not going to cover in this session, okay, then one of the goals here is to assist that patient's growth and development, because that's the period where there's, in adolescence, there's that growth spurt that is happening. There's maturation, pubertal maturation happening. So that needs to be accounted for. Next slide, please. Protein requirements. So in adults with CKD 3 to 5 who are metabolically stable, we recommend, under close clinical supervision, i.e. from the dietitian and the physician, protein restriction with or without keto acid analogs to reduce the risk for end-stage kidney disease and improve quality of life. Now, for those of you who don't know what keto acid analogs are, they're actually proteins that help to delay delay the onset of kidney disease. But when it comes to studies, there are multiple studies that do support keto acid analogs and those that do not support keto acid analogs. Okay, but that's beyond the scope of this session. A low protein diet providing 0.55 to 0.6 grams dietary protein kilograms per body weight per day for CKD stage 3 and stage 4. And so that's approximately, I would say, 50 grams to 55 grams per day. Okay, and when you translate that into something practical, it's instead of eating the whole chicken slice, you'd be eating a third palm, which is actually quite a small portion. And the reason why the patient should be adhering to such a small portion is to prevent or delay the onset of dialysis, to prevent further deterioration of the kidney, and also at the same time to meet the body's protein needs. Okay, so the body still needs some protein, but at the same time, I'm interested in delaying hemodialysis from taking place. Or a very low protein diet, providing 0.8 to 0.43 grams dietary protein. This is, of course, aided with additional keto acids, amino acids to meet protein requirements. Okay, so you can see that there are two options here. There's a low protein diet without keto analogs, and there's a very low protein diet with keto analogs. Okay, and as I said here, when it comes to keto acid analogs, it's debatable. Okay, next slide. In the adults with CKD 3 to 5 and who has diabetes, it is reasonable to prescribe under close clinical supervision a dietary protein intake of 0.6 to 0.8 grams per kilogram body weight per day to maintain a stable nutritional status and optimize glycemic control. So this is actually a recent clause which has been included. In diabetic patients, of course, we all know here that there's an aberration or there's instability of blood glucose. And when you add slightly more protein, you're actually helping, you're contributing in keeping that serum glucose and fasting blood sugar stable for that patient. And how do you do that? By adding slightly more protein. Next slide. In adults with CKD 5 on maintenance hemodialysis or peritoneal dialysis who are metabolically stable, we recommend prescribing a dietary protein intake of 1 to 1.2 grams per kilogram body weight per day to maintain a stable nutritional status. I'd like to mention here that I've looked at other guidelines, not just the KDOQI ones, the CARI guidelines, the ESPEN guidelines, and they would say roughly the same thing. In some cases, it's 1.4 grams per kilogram per day. Okay, I just want to make sure, are you able to hear me?
Yes, well.
Okay, thank you. Okay, so moving to the next one. In adults with CKD 5 and who have diabetes, it's reasonable to prescribe dietary protein intake of 1 to 1.2 grams per kilogram per day to maintain a stable nutritional status. And for patients at risk of hyper and or hypoglycemia, higher levels of dietary protein intake may be considered to maintain glycemic control. Next slide. So when it comes to protein source, I'd like to mention, first of all, that when I first joined practice, it was made clear to me that a patient should be taking protein which is of higher biological value. What does that mean? That it has a complete amino acid profile. It has to come from animal sources, and that's the way it's better absorbed. But according to recent guidelines, which I'm going to read right now, in adults with CKD 1 to 5 or post-transplantation, 1 second, there is insufficient evidence to recommend a particular protein type, plant versus animal, in terms of the effects on nutritional status, calcium or phosphorus levels, or the blood lipid profile. Next slide, please. Dyslipidemia, which is abnormal serum investigations of lipids. In adults with CKD 1 to 5, not on diet, dyslipidemia, we suggest that prescribing a Mediterranean diet may improve lipid profiles. And in adults with CKD 1 to 4, we suggest that prescribing increased fruit and vegetable intake may decrease body weight, blood pressure, and net acid production. Okay, next slide. Okay, and then now on to nutrition support. And nutrition support can be oral, enteral, or parenteral. And when do we start with nutrition support? When a patient is unable to eat normally. Okay, so if a patient is unable to meet his or her requirements through dietary means, normal dietary means, eating regular breakfast, lunch, dinner, we start with an oral supplement. And if an oral supplement is not feasible, we start with an enteral nutrition, whether it's through NGT or PEG or PEJ. Okay, depends on how long the patient is going to be taking that nutrition support. Or if none of these work, we start with parenteral nutrition. Okay, and that depends on the function of the gastrointestinal system. So in adults with CKD or post-transplantation at risk or with protein energy wasting, we suggest a minimum of a 3-month trial of oral nutrition supplements to improve nutritional status if dietary counseling alone does not achieve sufficient energy and protein intake to meet nutritional requirements. In adults with CKD 1 to 5 with chronically inadequate intake and whose protein and energy requirements cannot be attained by dietary counseling and oral nutrition supplements, it is reasonable to consider a trial of enteral tube feeding. Okay, and in the same category, if none of these work, we suggest a trial of TPN and interdialectic parenteral nutrition to improve maintain nutritional status if the nutritional requirements cannot be met with existing oral and enteral intake. Next slide. Okay, when it comes to micronutrient intake, so this is mostly, it's a common problem with maintenance hemodialysis patients and peritoneal dialysis patients, because with dialysis, they could be losing all those vitamins and minerals. And it's not just losing it through the dialysis, it's also losing it because of restrictions of fruits and vegetables that are high in potassium in some cases, depending from one patient to another. So that could be a concern. So in adults with CKD 3 to 5 for post-transplantation, it is reasonable for the registered dietitian or an international equivalent to encourage eating a diet that meets the recommended dietary allowance for adequate intake for all vitamins and minerals. Okay. In adults with CKD who exhibit inadequate dietary intake for sustained periods of time, it is reasonable to consider supplementation with multivitamins, including all the water-soluble vitamins and essential trace elements to prevent or treat micronutrient deficiencies. Now, I just want to exercise caution. I would exercise caution when implementing any of these guidelines, especially with micronutrient intake, because some patients could be at risk of hyperphosphatemia or hyperkalemia. Okay, so if I'm going to give a multivitamin or multimineral supplement, I need to discuss it with my physicians first, okay, whether that supplement is safe. And even if the patient is considering taking a supplement, okay, he should discuss it with the dietitian and the physician first. Okay, And so the dietitian will be doing his or her assessment to understand what the patient's eating, and if it's absolutely necessary to take a micronutrient or multi-mineral or multivitamin supplement, then please do. Next slide. Phosphorus. Phosphorus has always been a problem for hemodialysis patients. So in adults with CKD 3 to 5, we recommend adjusting dietary phosphorus intake to maintain serum phosphorus levels in the normal range. So if the patient's serum investigations indicate that the patient is having hyperphosphatemia, then dietary phosphorus needs to be restricted. And dietary phosphorus can come from inorganic and from organic sources. Inorganic sources come from food additives, okay, and processed meats, and these the body absorbs 100%, so they're bioavailable 100%. But if the patient is taking phosphorus from natural sources, okay, their bioavailability is slightly less. So from meat, chicken, or fish and beans, the bioavailability is about 70%, and if they're taking it from vegetables, due to the presence of phytates, their bioavailability is about 30%. The word bioavailability means how much the body is absorbing from that nutrient, by the way. Okay. In adults with CKD 1 to 5 or post-transplantation, it is reasonable when making decisions about phosphorus restriction treatment to consider the bioavailability of phosphorus sources, like animal and vegetable additives. For adults with CKD post-transplantation with hypophosphatemia, it is reasonable to consider prescribing high phosphorus intake, dietary supplements in order to replete serum phosphate. From my own personal experience, rarely do we see patients whose phosphorus is low. Mostly I've seen patients' phosphorus who's high, but then if you do have patients with low phosphorus, assess them accordingly and treat. Next slide. Potassium. And this has always been a problem in hemodialysis patients because, so I'm going to share my experience because in my experience, most of the Omani dishes are actually high in potassium due to the presence of tomatoes, due to the presence of potatoes, okay, and also the consumption of banana and dates is sort of like a staple in the Omani diet. So, a message to our dietitians is to assess and to treat, to implement a medical nutrition therapy that addresses these issues. And also, it's a good idea that we work on recipes, okay, that are low in potassium, but also at the same time are palatable to anybody who wants to consume them. So in adults with CKD 3 to 5 or post-transplantation, it is reasonable to adjust dietary potassium intake to maintain serum potassium within the normal range. In adults with CKD 3 to 5 or post-transplantation with either hyperkalemia or hypokalemia, we suggest the dietary or supplemental potassium intake be based on the patient's individual needs and clinical judgment. So if the patient's potassium level is low, we might increase his dietary potassium intake, but that needs to be done very carefully and under the supervision of a dietitian and a physician. If it's high, then we need to lower that. And also I'd like to add one more thing here is to rule out the non-dietary potassium reasons, because that could be the culprit. It could be some medications, it could be potassium-sparing diuretics, it could be that there is GI bleeding, which I'm sure I don't need to remind you, but then it's always important to work together in this issue. Next slide. Sodium intake, of course, any patient who has a high blood pressure should reduce his sodium intake from processed foods and processed meats. And renal patients are no exception. And one of the main reasons is because the patient's kidney function is deteriorating. The kidney is unable to maintain that salt-water fluid balance anymore, and needs to depend on outside sources to do that. So in adults with CKD 3 to 5 or post-transplantation, we recommend limiting sodium intake to less than 100 millimoles per day. In adults with CKD 3 to 5, we suggest limiting sodium intake to less than 100 millimoles per day. And in adults with CKD, we suggest reduced dietary sodium intake as an adjunctive lifestyle modification strategy to achieve better volume control and a more desirable body weight. So what the dietitian would be doing with this patient is to carry out an assessment, and from the diet history and from the entire medical history, if the patient's intake of processed foods is high, then the dietitian will be providing a medical therapy plan to help the patient reduce his sodium intake by suggesting alternatives to the processed foods and instructing the patient or the caregiver to prepare foods at home with less sodium and to use other flavoring enhancing substances that don't increase the sodium and increase blood pressure and fluids. Next slide, please. Okay, so we're sort of near to the end. This is sort of like a summary of the nutritional requirements of patients. Okay, just going to go over very quickly through that. Calories, okay, 35 kilocalories per kilogram per day for stage 1 to 4. Stage 5 hemodialysis, again, it's the same thing. Hemodialysis and peritoneal dialysis. For the elderly, above 60 years old, it's slightly less than that because the baseline metabolic rate is going down. Now, one more thing I wanted to mention here is for children, adolescents, it's probably going to be slightly higher, but it's most guidelines would state that their requirements are the same as their normal counterparts. Okay, so I need to take into consideration the growth, their development, and address malnutrition if it's there, if the patient is taking insufficient nutrients to meet his growth needs, then proper dietary intervention needs to take place. When it comes to protein, okay, stage 1 to 4, 0.6 to 0.75 grams per kilogram per day. For stage 5, hemodialysis, 1.2, and for peritoneal, 1.2 to 1.3. Okay. When it comes to fat intake, the lipids intake, okay, I don't want to go into further details with this, but it's pretty much the same as someone who has a risk of, has a high risk of cardiovascular disease, because the kidneys have lost their function in producing what's called nitric oxide, which is a vasodilator. Okay, so less than 10% saturated fat. Of course, the recent guidelines are saying less than 7% of saturated fats, and saturated fats come from meat, from red meat, from whole fat dairy. Okay, and also 250 to 300 milligrams of cholesterol. Okay, and the dietitian can provide further support in that. When it comes to sodium, okay, some guidelines would state 2,000 milligrams per day, and in some cases is 1,500 milligrams per day. Potassium, okay, so for stages 1 to 4, usually it's to match to lab values. So if the patient's potassium level is normal, then I don't need to address the potassium. On the contrary, I'll just let him eat, but not liberally. Okay. For hemodialysis and peritoneal dialysis, of course, it needs to be restricted. But again, even in my own personal experience, when patient's potassium level is normal, okay, then I don't address potassium in this regard. I will address potassium when that patient's potassium levels are high. But then there of course needs to be some sort of education in the very beginning. But I don't want to overwhelm the patient, so that if the patient is just given instructions to, you know, to avoid everything, then that could have detrimental consequences. The patient is not really eating sufficiently to meet requirements, metabolic requirements. So he's putting himself into further deterioration. So I would provide an optimal medical nutrition therapy that aids the patient in prognosis, remission, and also help the patient maintain his nutritional status. The vitamins, the minerals, the serum investigations are normalized. When it comes to calcium, so for stages 1 to 4 CKD, it's 1,200, which is pretty much the same as any normal adult. Okay. For stage 5 hemodialysis and stage 5 peritoneal dialysis, less or equal to 2,000 from diet and medications. I just have to make sure in this particular instance that the patient is not over-consuming calcium, you know, to prevent what's called vascular calcification. When it comes to phosphorus, stage 4 to 5, matched lab values. If the patient's phosphorus levels are normal, then we stay that way. If it's high, then we act accordingly. Stage 5 hemodialysis and stage 5 peritoneal dialysis, it's 800 to 1,000 milligrams per day. And also, of course, the patient is to be taking phosphate binders. When it comes to fluids, usually for stages 1 to 4 CKD, if the urine output is normal, then the patients can consume fluids. I'm not going to say liberally here, but maybe you need to exercise some caution, but not as much as he would in stage 5 hemodialysis and peritoneal dialysis, which in case needs to be monitored. Okay, it's usually 1,000 plus urine output. And from my experience, I used a separate method which I learned from a reliable source, and I used that accordingly. Okay, next slide. So I'm going to conclude with the summary of recommendations. Nutrition care for patients with CKD should be individualized, taking into account the patient's individual needs, stage of kidney disease, nutritional status, and comorbid conditions. Multiple factors can attribute to the increased risk of protein energy wasting or malnutrition. Routine assessment of nutritional status at least biannually is suggested to prevent and or treat malnutrition. Adequate calories are required to prevent catabolism or protein energy wasting in adult patients. Next slide. Protein requirements can be highly variable and require individual assessment by a registered dietitian. A stepwise individualized approach is recommended. Protein recommendations should be individualized and based on patient preference for animal or plant-based protein. It is recommended serum potassium be regularly monitored, so of course the monthly investigations, and patients receive education regarding dietary potassium restriction once serum potassium levels are elevated. Next slide. Unless otherwise directed by patient's physician, total fluid intake for patients with CKD does not need to be restricted. So it's going to depend from one case to another. The recommended daily sodium intake is less than 2,300 milligrams for individuals with CKD stages 3 to 5 and on dialysis. For patients with hypertension, the recommended daily sodium intake is 1,495 to 2,300 milligrams, in addition to antihypertensive medications and or diuretics to control blood pressure and proteinuria. Again, I would just like to say here that the dietitian plays an important role in educating the patient because the dietitian most likely understands food labels, understands what foods have how much sodium in them and what alternatives can be used. General multivitamins are not recommended in individual CKD due to their vitamin A content. Supplementation of vitamin A is also discouraged. And by the way, vitamin A is a fat-soluble vitamin, so all fat-soluble vitamins can accumulate very quickly. Again, as I said here, it really, when it comes to supplementation, it's going to depend from one patient to another. But as I said, also in hemodialysis, because of the restriction of high potassium fruits and vegetables, the patient may not be taking sufficiently from vitamins and minerals, so may need a supplement with precaution. Referral to an RD is recommended for patients with declining kidney function to ensure nutrition adequacy and reduce nutrition risk. Next slide. I think that's it, I believe. Okay, thank you very much. That concludes my session. And please, if you have any questions, I'll be happy to answer them.